Good afternoon, and welcome to Legacy RCM System Retirement, Expediting AR Liquidation and Cash Acceleration, a webinar tweet chat combo from HealthSystemCIO.com, sponsored by Galen Healthcare Solutions. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of HealthSystemCIO.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our managing editor and director of social media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the WebEx Media Viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel. Please be sure to type your questions in there. Leave the default to all panelists and send them in as they occur to you, and we'll take them later in the program. And you can download the deck by using the URL on your screen, and it's been sent out in the chat box. Just so you see how we're going to spend our time today, we're going to go about 30 to 35 minutes with Bob Downey, VP of Product Development with Galen Healthcare Solutions, and then we will have our Q&A with Bob. So again, send those questions in. So without further delay, I'm going to turn it over to Bob Downey. Bob, thanks for joining us today.
Hey, thanks, Anthony. So I believe this might win the award for the most long-winded presentation title ever to occur. I don't think I named this, just to put that caveat on there. But essentially the goal of today, if I go to the agenda, is to take you folks through some of the concerns and some of the things that come up during system retirement as a whole, but with a specific focus, obviously, on patient accounting and revenue cycle systems in general. They obviously have a lot of very specific nuances to them that are really important and can impact the strategies that you use to retire these systems, as well as the timelines that you can do that on. We're going to go into a lot of the details around what informs you as an organization that wants to retire these systems in terms of what the best strategy is. And then specifically, we're going to look at a couple of examples that are semi-real world. They've been kind of anonymized to protect the innocent, but we're going to look at some real-world examples of accounts receivable systems and how those systems were shut down and the strategies that were used to do so. And then obviously, as Anthony said, we'll have a Q&A session at the end. So Anthony already kind of introduced me, but I lead the product development team here at Galen Healthcare Solutions. What I spend most of my time on these days is our Archival platform, which is hence the reason I have knowledge about this problem domain. Galen retires a lot of these types of systems, and so we've encountered many, many different variances and nuances in terms of customers with very unique problems in this space, especially around the patient accounting side of things. And so that's where my experience comes from here. Really briefly about Galen. We've been around for a long time, hence the 2005 founded. We've spent that entire time doing, healthcare IT-related activities, and over the last, I would say, 8+ years, most of our efforts have actually been focused around the topic of today's presentation, which is retiring systems, both clinical and financial and ancillary systems like ERP-related systems. So I would say probably half or more of our business these days is surrounding the retirement of systems within a clinical space. And we're good at it, apparently, according to KLAS and a variety of others. So this is a really good kind of busy slide that shows you a lot of the different concerns and topics and steps that you often go through when retiring a suite of applications within a healthcare system. Healthcare is an interesting space where it is very common, at least it used to be common, that you would have not one or two or three critical applications to your business, but dozens, all of which kind of tie into each other in very complicated ways, and certainly revenue cycle is not the least of those in terms of that complicated integration pattern. And so when we go into an organization to help take them through the retirement process, we're often not brought in just for a single system, but how those systems interact with each other and the sort of mesh, if you will, of dependencies. And so we take a very careful approach and a methodical approach to go through that. And a big aspect of that is how revenue cycle is going to be handled going forward. So you can see that down there, kind of on the third line from the bottom, there's one path or timeline related to revenue cycle, which starts with accounts receivable analysis. It turns out that, and we'll go through this in a lot more detail in a second, but it turns out that a significant contributing factor in how you retire these systems is entirely based on what that AR profile looks like in those systems. The different receivables you have, their age, their type, all directly influence how you're going to end up retiring that system and the timeline you can do that on. And so that's usually where we start this process, and where we're actually going to spend a lot of today talking about how to do that type of analysis and what those potential solutions can be depending on how that analysis shapes out. And then ramping down those revenue cycle systems so that you can get to the point where the systems that the AR is sitting in now and all of those other systems that depend on that system can be shut down, deprovisioned, and you can obviously save significant expense once you've gotten rid of those systems. So in terms of specifically analyzing AR systems, but just in general, when we go and look at a specific clinical system of any kind, we're looking at contracts and terms of those existing systems, retention requirement rules. There's a lot of things or bubbles that kind of feed into the decision matrix for the retirement of those systems. But a big one, and this is an especially important one in the case of AR, is how you're going to continue your business. With clinical systems, there's certainly still some business continuity aspects that are required. A lot of it's reference. A lot of it is going back into these old systems to reference clinical data so that you can make clinical decisions or produce release of information. But this problem, so to speak, is exacerbated, obviously, on the patient accounting side of things. There's usually a significant duration of time where you simply cannot stop using those old systems. There's a huge amount of revenue that's dependent on actively using these systems and continuing to record net new information in them. And it's traditionally very difficult to move that information out of those systems like you might with clinical data. Obviously, one of the things that Galen does is move this type of data from old systems to new systems. But what I will say is that it is much more common to move clinical information forward into your new platform, whatever that might be, than it is financial information. And there's a lot of good reasons for that we're about to go through. So looking at an existing accounts receivable system and a patient accounting system, the important factors that you're going to look at to figure out the best strategy for shutting down, or I'll take a step back, potentially shutting down that system, because there are scenarios in which maintaining that system in perpetuity actually does make sense, and we'll talk about those in a second. But the important factors that go into that decision matrix, as you can see, the number one factor here is your AR profile, is what does your existing receivables look like, and what is the lifespan or duration those receivables are expected to survive or last or have some kind of value. This can vary a little bit between professional and facility-based billing situations, but what's interesting is that while their makeup differs, what you'll see when we get into the AR profile section of the presentation is the outcome or the timeline that you're going to use to associate the majority of the value in that system, how much do these receivables actually mean to you as an organization, what's their net value, actually does not differ significantly between professional and facility-based billing situations. And that's something that we've teased out of the data over the years of doing this. The existing revenue cycle vendor is obviously very important. One of the primary driving reasons you want to get rid of these systems is that whether it's a standalone revenue cycle product or a revenue cycle product that's integrated in with a larger clinical suite of applications, it's usually very expensive. It's very difficult to secure minimal licensing that you might think that you might be able to get from these vendors as you're ramping down. One valuable lesson we've learned over the years of doing this is that there is no more hostile entity in healthcare IT than the one that you've already told you're leaving. They have very little reason to cooperate with you from a contractual perspective. So unless you've got a very careful legal department that has written in all of the exit clauses you could ever need into these contracts, you're often in a place where they're going to extract as much money as is possible. Another complicating factor are those revenue cycle vendors that end up taking a percentage of your accounts receivable in exchange for the the software license itself. And I think we can all name those vendors if we needed to. But those become an even more complicated scenario because oftentimes those revenue cycle vendors will have a minimum billing threshold and a minimum account activity before they start charging you above and beyond that percentage that they typically get. And that can force you to accelerate your timeline significantly, depending on, again, what your AR profile looks like. Obviously, the cost to run these systems can be huge, whether you're doing outsourcing and staff augmentation to run them from a staffing perspective, whether you're hosting them remotely or hosting them on site. All of these systems can have a very large price tag. I mean, that's one of the primary drivers behind retiring clinical systems in general, is that continuing to run them when they're not a primary revenue generator for organization is just not usually financially feasible. Sometimes it is, and we'll talk about that, but usually it's not. The future revenue cycle vendor turns out to be a very important one. Now, obviously, the organizations out there that are winning new business, you can probably count on one hand, with 2 or 3 of them representing the vast majority of the market. And so what they allow you to do in terms of, for example, moving data into their environment ends up being a really critical aspect of your solution criteria. So, for example, if the vendor is actively hostile to moving revenue cycle data into their environment so you can continue to run your business using data that was not generated in their product, that if they actively advise against that or even outright say you can't do it, that limits your potential solutions dramatically. I will say that this has been a common issue for years, where the sort of winning vendors out there, the ones that everybody are moving to, have often been fairly hostile to bringing data into their environment, and that attitude has changed dramatically, especially over the last 2 or 3 years. A lot of that's just because of the success a lot of customers have had moving their data into those new vendors, but to a large extent, as I mentioned previously, that's been mostly limited to clinical information rather than financial data. And then finally, obviously, release of information, retention requirements. This will define what your kind of long-term timelines are for preserving this data and preserving the systems in which this data exists. For the most part, these are pretty consistent, and we've got a whole section in just a second that talks about this. But obviously, if you're planning on keeping the existing system, for example, to maintain that, if you've got your existing revenue cycle system and you've decided that the best way forward is simply to maintain that system, you have to assume you're going to be maintaining that system across multiple hardware refreshes, multiple operating system and dependency refreshes, significant staff turnover during that time frame, because you're looking at 7, 10, 15, 20 longer years that you're going to be running those systems. So you have to be very careful about considering that as a potential solution. So related to retention requirements, obviously the reasons for retention are pretty well known. A lot of it is simply the letter of the law. A lot of this financial data is undoubtedly part of the designated record set in your organization, and certainly is part of the designated record set as is defined by kind of general guidelines, which means that it can certainly be part of e-discovery and any kind of request for record. So most organizations define a fairly limited subset of patient information for the legal medical record. Oftentimes, their goal is to limit the scope of that legal medical record as much as possible to make it easy to produce for third parties. But that legal medical record will often result in follow-up discovery and in additional questions. And so anything that's part of that designated record set for the patient, and really the courts can ask for essentially anything, as I'm sure everybody's aware, but is most commonly restricted to things that are in your designated record set, and billing and financial information statements, et cetera, are all part of that. So from a legal perspective, what we find is that most groups are keeping this financial data at least as long as the minimums for clinical information for your legal medical record, and more generally for that designated record set. And over there on the right-hand side, you can see a impossible to read spreadsheet. I apologize. You might be able to read it better when you download the presentation itself, but this is kind of a very high-level grid that shows you different states and the different clinical requirements in terms of how long you need to keep that data. And most of the groups and the organizations that we work with use this as a blanket retention requirement for both clinical data and for financial data, specifically patient-related patient accounting data. So in some cases, especially in facility billing scenarios, you're going to end up keeping a lot of that financial data for a significant period of time. A decade or more is not uncommon. And so that can certainly affect your plans in terms of keeping those existing systems running. Obviously, other drivers for retention are audits and takebacks. These types of rack audits that have become more frequent in recent years. They can happen up to 3 years after the finalization of that claim submission to generally to Medicare. And so for 3 years, you might have to go back and provide both financial and clinical documentation that justifies how care was delivered and how it was billed and the level of services, for example, that were used. That can be onerous, obviously, and especially becomes onerous as the folks that used to use those systems become less and less familiar with them. So relying on those old systems that you might preserve, for example, for years to come to be able to handle these type of audits can actually get more difficult over time as your users' familiarity with those systems decreases because they haven't been actively using them to any significant extent for many years. But that's a big driving factor, especially in the first 3 years, to have this data readily available. And then one thing that's often missed, shockingly so, is the value of this data in and of itself. Your financial billing claims information is some of the most valuable data that you have. One of the reasons for that is that it is standardized and forced to be standardized by the fact that there's a standardized format for submitting claims and handling those types of receivables. And so because of that heavy amount of standardization in the data, it makes it much easier to analyze and report on and develop, predictive models based on older data. So it actually is usually the first thing that folks go to when they're trying to develop some kind of predictive model for how they're delivering care and how they can reduce risk for their organization. And so simply dropping that data, you're losing a huge valuable asset in your organization if you do so. And that's one thing that we see very often asked during the retirement process is how do we continue to do reporting and analytics and integrate this in with our go-forward reporting and analytics strategy, even though these systems are going away. So in terms of the cost of these systems, obviously one of the goals is to reduce costs here, if not the primary goal, is to reduce cost of running these systems. You don't want to have to pay for many, many, many different revenue cycle systems or any of these types of healthcare IT systems. When going forward, you've got your one chosen platform, and it makes it much harder to run your business if you have all of these dangling contracts and dangling costs, especially from an IT perspective. So we won't go through each of these in a ton of detail because I'm sure everybody on this webinar has gone through this type of exercise many, many, many different times. But at a high level, it is really, really important to analyze the total cost of ownership of these legacy systems, especially when it comes to revenue cycle systems, because in the case of revenue cycle systems, the value of that system and the AR that's in it oftentimes masks the costs of running those systems. You might look in an existing revenue cycle system and say, hey, we've got $50 million in AR in that system. That means that the fact that this system only costs us, so let's say, $250,000 a year to run means that we should keep that system around for a long time so we can burn down that AR. What we'll see in just a second, once we get into the AR profile analysis, is that ends up being almost certainly not the case. The value of that AR, especially once you're out more than about 90 days, drops like a rock, as I'm sure many of you are aware. And so what's really important is not just looking at sort of comparing two numbers, the total cost of ownership or the sort of high-level cost of ownership of one of these revenue cycle systems and the outstanding AR you have in it. It's much more about seeing where there's an inflection point in terms of your return on your investment for keeping this system around, and we'll dig into that in a lot more detail in just a second. So what are the potential strategies for shutting these systems down and getting rid of them? Well, we've kind of narrowed down most of the strategies, and there are nuances certainly in all of these, but the kind of high-level categories we have are here on the screen, and they're roughly organized by complexity, with the least complex from an IT and sometimes cost, but certainly just IT and project management perspective and disruption to your day-to-day business activities perspective would be status quo, as you might expect. Just doing what you're doing and not changing that has the least complexity. You get to keep running those systems. The folks that have already used those systems will continue to use them. Their activity will go down over time. You have unlimited flexibility in terms of how long you actively pursue the AR that's sitting in those systems, which is oftentimes very attractive to groups. And eventually that system essentially moves into a almost read-only mode where you're only using it to release some information. You're only using it to answer the one-off request for statement reproduction or designated record set e-discovery type situation. It's certainly very attractive from that perspective because it's a known quantity. You know exactly what you have, and that won't change. There's downsides to that, which we'll get into, but obviously the biggest downside is that usually from a cost point of view, that's not tenable. The long-term cost of these systems end up dwarfing the value of their existing AR. So usually it means that you want to get that data out of those systems so you can shut them down. They weren't ever meant usually to provide a read-only reporting type scenario. It was their cost models were built around the idea that you were generating revenue from those systems, and once you're not, usually the ROI simply is not there. But it's attractive. Keeping it as it is a very attractive option. The next strategy, and this is the one, hint, this is the one that we end up recommending the most to our customers because it's a good blend of more complicated scenarios that might, get you a little bit of extra return versus the status quo, which usually will end up shooting you in the foot long term. The rapid burn down scenario is where you go in and you aggressively pursue the existing receivables for a limited window, and you are very strict about that limited window. You'll sometimes couple this strategy with an early out vendor, which we'll talk a lot more about a little bit later on. But the scenario might be that you might have, for existing patient payment plans that have long trails on them in terms of the high value revenue you might receive from them, or maybe your AR portfolio shows you that you do end up recovering significant receivables, 6 or 9 months out. That's unlikely, but it might, and that's one of the reasons you do an AR profile analysis before you make these decisions. In any of those scenarios, it might make sense, depending on when the inflection point is for when your ROI starts heading in the wrong direction, to use an early out vendor to get rid of that existing AR and achieve some short-term realization of that AR while you can still move the rest of the data off into the archive and handle all of those long-term scenarios. A variant of this in many ways is balance forward, which is the next on the complexity line. So in a balance forward scenario, maybe in addition to using an archive, you're often bringing forward high value accounts or a subset of account types into your go-forward system, into your go-forward EMR that has a patient accounting module in it, for example. And those scenarios are attractive when your go-forward vendor encourages that or has facilities to support that, and most of them do. Most of them don't encourage it, but most of them do have facilities to support the automated import of account information and account balances and historical data. And then you would end up bringing forward only those that were active or only those that were particularly high value or had, like, for example, the patient payment plans. And you'd run those down in your go-forward system while moving everything else off into the archive. That has a lot of different benefits in it. It gives you that same flexibility for your high-value accounts to continue to burn down that as long as you see fit, because it's sitting in your go-forward revenue cycle system, which you're going to be paying for anyway. And it still preserves your ability to report on and analyze all of the historical data without being forced to bring that into your go-forward system, because it'd be sitting in an archive for historical reference. And then finally, full migration, this is kind of the other extreme end from status quo, would be you're shutting down that old system and you're moving everything into a new system, whether that new system is your go-forward EMR, which is, I would say, unheard of, or your new system is an archival solution that has patient accounting capabilities in it that allow you to burn it down. And so that full migration usually involves the highest amount of effort, but also offers you the greatest amount of long-term flexibility. You get to shut down the old systems. You still have an archive, and that archive or that go-forward EMR serves as the historical record that you can produce anything you might need to be able to produce and handle any kind of audits you might need to be able to handle. And you have total and complete flexibility in terms of how long you burn down that existing AR. And we'll get into some of the downsides of these various approaches in just a second, but that's the kind of overview of the typical tactics that we see customers using when they're retiring some of these systems. So what informs which one of those you're going to use? It's all about your AR profile. This is the single most important thing you can do, maybe besides analyzing your existing contracts and knowing when the big key dates and key expenses are related to those contracts. This would be number 2 or maybe number 1A in terms of analyzing your existing AR profile. You need to understand where you stand from an aging perspective, which everybody will. Virtually everybody lives and dies by these types of benchmarks. So you have all of the reporting and analysis that you typically would need, usually at your fingertips, because it's a primary input to how you run your business. But you need to understand exactly when you are likely to receive monies that are sitting in your outstanding AR, and then being able to look at those different buckets in terms of aging days and understanding what the true value is of those dollars. So a value of $1 sitting out in greater than 120 days is obviously not the same value as $1 sitting in 0 to 30. It has a dramatically different value. And this ends up being something that organizations generally don't want to or don't take into account, at least, when they're looking at the total cost of ownership versus the return on investment for continuing to burn down that AR. They're ignoring the fact that $10 million is not actually $10 million in their AR. It might be pennies on that, depending on how old that AR is. And continuing to try to burn down that AR has no real return on your investment and ends up just costing you money in a wide variety of different ways. So this AR analysis and comparing yourself against general benchmarks and looking at how you've been trending historically becomes critical. This is obviously also something that you need to consider when you're moving to your new AR platform. One thing that I'm sure everybody on here has heard stories of is when you transition from one vendor to another, there's a period of time where your receivables mysteriously drop in many cases. It doesn't happen as much as it used to when there was a lot more activity moving to, one of the top 2 or top 3 big vendors, and you had those, reports coming out of all of a sudden your receivables were dropping by 20%, in various aging categories for mysterious reasons. And those can all really be attributed to the difficulty in transitioning from one complicated platform to another, and people end up missing things that they wouldn't have missed if they were using a platform that they were more comfortable with. So there's just a learning curve when you move to a new system. But these types of benchmarks and analyzing how your AR profile looks is a critical tool for making sure that's not happening to you. The faster you catch that when you've moved to your new AR system, the less of an impact it'll have. If you realize within the first 60 days that there's been a significant change in the likelihood of getting receivables in certain categories, that can allow you to narrow your focus to figure out why that's the case and resolve it quickly. So no matter what you end up doing, this should be one of the first things you analyze to make sure you've got those benchmarks ready to go. So if we look at, so this is an interesting few stats. Some of these are more shocking than others, but the chance of you realizing receivables drops by 30% or more in many cases, depending on if it's depending on the account value and whether it's a facility or a professional services billing scenario. But the value drops 30% for every 30 days it's sat in your receivables bucket. That's a pretty shocking stat. Now that particular value is focused largely on self-pay and patient payments, not on insurance, and we'll break that out in a second. But that's a stat that I'm sure many people have heard before, but it's still fairly shocking, the fact that value drops so rapidly. 6%, wow, the odds of somebody paying off an account after they've been sent their fourth statement. So that generally would mean that your receivables are over, say, 120 days, and you keep sending statements out to a patient, you've got essentially no chance that that patient's going to end up paying. So that means that you need to adjust the value of those receivables sitting in your buckets accordingly. You can't just look at it as face value. And then the one that I personally found most shocking was 11% the chance of somebody paying any balance over $500. So and this obviously happens more often in a facility-based scenario, an acute care scenario, but the odds of a patient paying any balance over $500 is only 11%. So these types of stats, they might vary, they definitely do vary from an organization to organization, but these are the types of things that you need to analyze using your existing AR system to predict what the value of the AR is going to be so that you can get a total cost of ownership versus ROI calculation clear in your mind and make a decision that makes the most sense from a bottom line perspective. So let's look at and this again is a semi-anonymized AR profile that we've put together. This is actually a blended profile. It includes both acute and ambulatory scenarios, professional and facility-based billing for scenarios. And it's a little hard to read, to be honest with you, but if you look at the top, you've got your aging category, you've got your payment category. We've simplified it to just be patient and insurance in this case. So 60% of all AR outstanding was patient-based and 84% is insurance-based. And then you can see the breakdown in the specific aging category there in the grid. And if you do the math on these various things, you'll see that the average amount of age for a given patient account is 78 days. That should be a giant red flag, and it's not going to be uncommon, obviously, but that should be a giant red flag if you're counting on significant patient self-pay receivables. And you look at your existing profile and it looks somewhat similar to this, where you have a good chunk of it out past 90 days. That has a tiny fraction of its existing value. In fact, it has about 23% of its face value after that 90-day period. This is a real-world example, but the industry benchmarks out there that everybody can look up are not far off this. In fact, this is not particularly bad. This is kind of middle of the pack in terms of benchmarks. So if you think your organization is dramatically different than something like this, make sure that you've got the reports and the data to prove it, because that's really important. It means you guys are doing great, but it also could be a suggestion that maybe the numbers aren't exactly what you think they are, because these are, the industry benchmarks are benchmarks for a reason. In terms of average insurance age, obviously there's a huge difference there. Unsurprisingly, insurance pays reasonably rapidly unless there's something fundamentally wrong with the claims. Obviously, there's slight variances there depending on the types of claims that are going in and when they went out. But generally, you're looking at the vast majority of payments coming in within that first 30-day bucket, which is great. And even the ones that don't come in within that first 30-day bucket have huge value associated with them. You're going to expect to get most of that money, even if it's left in AR for 30 or 60 days. In fact, 87.5% of all of the receivables that you've built out for insurance, you can expect to get back within that first 90 days. So that insurance bucket, the long-term receivable numbers there, they still drop fairly rapidly in terms of their value. If you're out 160 or more days, it's highly unlikely that those receivables will ever come in. But it's a different story, obviously, than the patient-based receivables. Usually those receivables don't come in because they're being shifted off to patient responsibility. Maybe the claim information was incorrectly filed, or there's a million reasons why that can be the case. And that information would get shifted off, or that those billings would get shifted off to the patient, and then the clock kind of gets reset there. But the big number here to focus on, and the one that's really important, and the one that you should have available to you when you're making these decisions, is that last segment there in the bottom right-hand corner. The 81% of all of the value you can expect all of the money you can expect to realize from your AR happens within 90 days. So you cannot look at an existing AR profile in a system that for example, we run into a lot of customers that have revenue cycle systems that have not been active for 6 months, and the customer will say, well, we've got $30 million in AR sitting in there. That might be the face value of that AR, but it's actually about 20% of that, or actually in that case, if it's 6 months old, a lot less than that. So those are the numbers you need to look at. You need to look at the actual value of that AR when you're comparing it from an ROI perspective to the cost of running that system or to the costs of your strategy for transitioning that. For example, if I've decided that I'm going to do a full migration into a new patient accounting system and the value of the AR, its face value, actually needs to be discounted by 80 or 90%, what's left over has to be less, obviously, than the cost of doing that migration into the new revenue cycle system. If it's not, why would you possibly do it? What scenario in which would you ever need to move that AR? You're not going to get the money back for it. It's going to be end up being a losing cause. So this is a fake $1 million in accounts receivables using that previous AR profile, and you can see here this is just kind of a visualization about how essentially all of the activities happening in that first 90 days, both for patient and insurance-based payments. You can see that the kind of purple line there, the grand total, realizes the vast majority of its incline, of its gain within that first 90 days, and from that point on, the receivables that are realized approach zero. I mean, you're not going to gain much of that money back past that first 90 days. So it's really just a visual representation of what we showed before. So that informs your revenue cycle timeline, your archival timeline. So this is a typical one that we often recommend to customers. When you've got your active legacy system there, you can see there in the top left-hand corner, there's a bracket that says this is the active usage of that system. What active means is you're doing net new patient account activity in that system. You're actively adding new transactions. You're actively adding, submitting new claims from that system. It's an active system. You're using it. Somewhere towards the end of that, you've transitioned to your new go-forward system. And you're continuing to use the old system, but not for net new activity. You're using it for cleaning up and handling older activity, closing out patient accounts, recording receivables, handling any changes that might occur within that window, and that might last for, say, 6 months to give a generous number. So that if there's a 6-month period where you're not actively using it for net new activity, but you're still using it generally for burn down related tasks, and then you make a transition off into your go-forward platform, typically an archival solution. So the graph underneath it shows where most of the value occurs in terms of actively using that system, and you can see that's why it's strategically planned right around 6 months post-active use to stop doing active burn down in that system and use one of the strategies that we talked about previously, whether you're moving it forward or writing it off and doing an early out type vendor or what have you, to transition to the archive. Because at that point, the return on your investment is pretty static. You're not going to be getting any additional significant revenues out of that system, and it represents mostly cost rather than net new revenue. And this is essentially what we were just talking about. So the cost of the burn down has to be less than the value of the outstanding AR. Otherwise, why would you do it? It seems like an obvious thing, but we very frequently encounter customers that will want to burn down that AR essentially in perpetuity, even if that value of the AR has now dropped below the cost of doing it. And then the corollary of that is that the cost of the retirement of that system has to be less than maintaining the existing system. This one's usually an easier one. These existing systems don't tend to be cheap if you look at the TCO of them, and so it's usually a clearer picture in terms of when that needs to happen, but it's the combination of those two things that really drives the timing of the retirement of that system. If we look at my favorite way to analyze this, which we call inflection points, this is, again, an example using that $1 million in AR where the customer decided to keep the legacy system and continue to run it while they burn it down for, say, 18 or 24 months. And this is a very typical, although certainly arbitrary in our case, that we created it specifically for demonstration purposes, but this is a really typical scenario where you have a base run rate for the cost of running that system. That would generally include the staff, the basic IT resources, any kind of month-to-month ongoing cost to run that environment, and they're reasonably low. You can see they start off very low at the bottom left-hand corner, and so the top line there is the total recovery out of that system, and then the green line, the really important line, is what is our net value of that recovery? What is the total amount that we are realizing as an organization, which is obviously the total recovery minus the cost of doing it. And so it goes along pretty nicely for the first 3 months, but then you'll see at month 4, unfortunately, this customer experienced an SMA renewal, hence the reason you should be looking at your contracts very carefully for when these types of things happen. So that SMA renewal immediately killed the total net for this particular organization. You can see that the inflection point when your total net started to go down, go in the wrong direction, happened right at month 3 when that SMA renewal hit. So in this particular customer's scenario, there's almost no situation in which they should not have exited that system as rapidly as possible because of that SMA renewal pending. But maybe it wasn't possible. It's entirely common that you simply the timelines don't line up and you know you're going to be forced to pay that SMA. So then things move along and you still have a positive net. Obviously, we're not talking about losses at this point, but you're not recovering as much money as you could have if you exited from that contract a little earlier. But then around month 12, we got hit with a hardware refresh. So even if you end up not paying for support and maintenance, which generally is considered a requirement from a security perspective, but if we ignore the cost of support and maintenance for these types of systems, invariably the operating systems and the supporting software that surrounds them are going to have refreshes. And if you get unlucky enough to have that reasonably early on in your retirement process, that further impacts, obviously, your net recovery for that. And then finally, around 16 months, this whole effort turned negative because we got hit with another yearly SMA renewal. So in this particular customer's case, they should have exited the system as rapidly as they possibly could, and indeed their overall ROI started going down right around month 3 or 4. A more complicated but illustrative example here would be the migration of this AR data into a net new system, whether that's a secondary patient accounting system that you're going to treat as an archive, or into your go-forward patient accounting system that's part of your kind of go-forward platform choice. And in this case, it's more complicated because there's a lot more cost involved when doing this type of full migration strategy. It starts off in a very similar way, although immediately our net's a lot less because our licensing costs for these go-forward platforms generally are a lot more expensive than keeping it at least initially where it's supposed to be, or moving it into kind of a more static archive. So immediately our net's less on the left-hand side there. But the story gets worse from there. It doesn't get better. We end up having to take into account integration costs. If we're spinning up not one but 2 patient accounting systems going forward, you end up having to do integration with those systems into your GL, into your debt collection process, and all of those are usually added costs as you move through this process. There's going to be greater training involved because you end up having to train people now not on one patient accounting system but on 2, and sometimes that'll just mean using staff aug because your folks won't be able to handle both of those scenarios. At any rate, the story here is actually very similar. The inflection point happened almost at exactly the same time because in this particular case, the customer wanted to have a go-live that coincided as closely as possible with the go-live of their clinical systems. And so these costs were kind of front-loaded. But no matter where you put this cost, your inflection point, the point at which your net is going to go in the wrong direction, will happen almost the minute you start the process of moving this AR into a new system. Now, there are exceptions to this. We've run into customers, and I'll use a specific example while keeping the names out of it, again, to protect the innocent, that we're running a very expensive patient accounting and ERP system on an IBM mainframe that literally cost them $1 million a month to run. The whole software suite, I think, was $250,000 a year in maintenance, but the hardware on which it was running, the leased mainframe, cost them $1 million a month, which is obviously not a common scenario. That's a pretty extreme situation. But that would be a good candidate for this type of migration activity. They need to get off of that system, not with these total AR values, mind you, but they need to get off that system as fast as they possibly can because the cost of running that system dwarfs any cost of moving the data into a net new system. But that is generally not the case. That's an extreme outlier, but it's worth pointing out that it does happen. So one thing that can run, can really throw a monkey wrench in things are patient payment plans, or financed patient accounts. These, unlike general AR, that's simply old, these have huge long-term value. 92%, the value of a patient account that's under a financed plan is 92% after at least 2 payments. If you have an AR profile that includes a significant amount of these patient payment plans, almost invariably they are worth almost face value for the entire duration of those terms, assuming the patient's had at least a couple of payments. So that means that these can be real money. We have a lot of customers where, depending on what their existing patient demographics look like, they might have a significant portion of their patient population on payment plans. These are almost always best handled with early out. Most customers don't look at early out for patient payment plans because of their high value, their high long-term value. But when you're retiring a system, the important thing to take into account is the fact that system is now only costing you money. You're no longer actively generating net new revenue with your existing accounting system. So the equations start to change in terms of what the value of these accounts are. And so a great strategy usually for these patient payment plans is to take an 80 or 85% payout, again, depending on what that profile looks like of your existing financed accounts, and take it all up front in one lump sum. And so you end up paying a 15-point discount or a 20-point discount on that outstanding AR, but you get it right now, and you get to shut down those existing systems right now. So it's kind of a double benefit in terms of accelerating the cash, to use the term of the title of the presentation. So it ends up being a great strategy that is almost always used by groups that are shutting down these systems, and almost never used by groups that are kind of in a scenario where they're not considering leaving an existing vendor, because the numbers just don't generally make sense. So this is something important to consider. So to close out, and I know we're getting close to the point of questions and answers, but to close it out, what we find is, and I gave the hint to this earlier, is the best way to handle this is to do a rapid burn down of your existing AR, and then treat your go-forward solution as kind of a static archive that you're going to use for only basic activities like reproducing patient statements and handling RAC audits and the like, and do all net new account activity in your go-forward system, and combine that potentially with things like early out vendors to make that timeline as short as you can possibly make it, because your net or your realized return on investment for these systems starts dropping very rapidly after they're no longer being used actively. And I think that's it. Yes.
So Bob, what you're saying is it's very simple. This is easy, no problem. It's a no-brainer, right? Whatever you
Obviously.
do. Yeah, easy stuff. My goodness, wow. That was a lot of good information, and it certainly is a complex process. So we're ready for some Q&A. I've got some questions in. Go ahead and type them in, and we will look at them. I would imagine there's a good amount of questions out there. So first question, Bob. What acute hospital-based revenue cycle systems does Galen have experience with? And that is an actual question. That's not just a setup question for you.
Well, pretty much name them. And at this point, we've done 300 projects, data migration projects. So we've seen virtually all of them, but I can say that the ones that we see the most are things like STAR is probably one of the most common ones, or Cerner is a pretty popular vendor. Really, if you want to answer that question, the way to answer it is to actually look at the vendors that aren't gaining new market share, and those are the ones that we see the most, because folks are moving to, Epic. They're moving to some extent to Cerner, a little bit of Meditech in there, but the groups that are losing the most market share are the ones that we see the most, and certainly the McKessons of the world, to some extent the Meditechs of the world, are the ones that we see most often.
Well, do you have scenarios where people are moving within the same company from one vendor product to another vendor product within the same vendor company, but the products are so different that it's almost like a complete migration? Well,
we do now that there's been so much acquisition on the part of those vendors. The most common example would be Allscripts' recent purchase of McKesson. So that can result in that type of activity a lot. We also see the corollary to that, which is and I'll use Meditech as another really good example. Meditech folks moving to newer versions of Meditech, especially now with their new Expanse platform. That's becoming more and more common. But yes, that definitely happens.
And you would be called in on something like that?
It depends on the scenario. So sometimes if it's a similar enough product line within the same vendor, the vendor itself can handle a lot of that migration. It actually makes that full migration option the no-brainer, where normally it's extremely expensive. If it's the same vendor, sometimes that vendor will offer that full migration option and just move all of that data from point A to point B as part of that migration offering. That's becoming more common because they realize there's a huge roadblock to folks adopting the newer versions of their platforms if they can't move their data over. But it didn't used to be that common. So it really depends on the vendor and the specific product at hand.
Okay. Next question from the audience. I see you're using MGMA benchmarking. Is this geared to physician, hospital, or both? I would expect to see HFMA or some other benchmark for hospital.
Yeah, so the benchmarks we showed initially were exactly that, but the AR profile that I broke out later on was actually a blended approach of both to try to show it. If you actually look at the benchmarks and the stats within your organization, you're still going to see similar numbers in terms of you realizing the vast majority of your outstanding revenue within, say, first 90 or worst case scenario 120 days, which means the overall story is roughly the same, but obviously the details tend to vary a lot more in those situations.
Okay. Next question. We are implementing Epic October of this year. Currently, we use Meditech. Do you recommend certain existing staff be dedicated to AR legacy work down and dedicated staff learning Epic? Or is it effective for staff to work in both systems at the same time?
Well, effective is the loaded word there, right? Because Epic's training requirements tend to be pretty significant. We often see entire staffs on both the clinical and the revenue cycle side essentially disappear for many months as they're doing their Epic training, and it tends to be a significant workload. If your folks can handle that, keeping the same people doing both can be effective. What we see most of our customers doing is if they're having to maintain two systems for any significant period of time, they're often leveraging staff augmentation to do that. They'll reach out to one of the many well-known third parties that can come in and help you run down that existing AR and do the day-to-day business in your old systems while your folks focus mostly on Epic in this case.
Bob, I'm interested in learning more about the interactions between the IT executives and the patient finance, patient accounting, even the CFO. So you could say CIO, CFO interactions. You mentioned all the considerations that depend on the AR, how much is in there, the value of the accounts that are in there. And then we have a separate issue, the technology, the cost of the technologies, dealing with the vendors of those systems more on the CIO side. Do you need a lot of interaction between those two constituencies in a hospital to understand when, how, and all these kind of considerations? Seems like they're so intertwined, you need those two disciplines really talking.
Yeah, you certainly do. I mean, it can be difficult when the CIO's time or the other folks that are handling with the transition to new systems, a lot of their time is being spent other places during this migration, and this is one of 1,000 different things that they have to take into consideration as they're moving to a new, platform or vendor. But what I would say is that the most effective way to handle that is to have the folks on the finance side produce the raw data that allows you to get those key performance metrics, almost like key performance indicators, that you can then use to determine what the value of that outstanding AR is. There's going to be other considerations. Like one of the things that I neglected to mention, which is obviously critical, is that some organizations simply don't do things like early out. That would be especially we work with a lot of religiously affiliated customers, and those folks have a mission statement, or part of their policy is to never do early out. That totally changes the dynamics. So it might not actually be helpful in those scenarios, but one of the key things is going to be to have the financial folks very early on look at their historical AR profile and their performance metrics, and then provide those key performance numbers to the rest of the team that's helping with this decision so that they can take that into account when they're looking at contracting, when they're looking at the TCO numbers for the IT costs and the software licenses and various dates that are coming up in the future. And then they can use those performance indicators to determine the core question at hand, which is what is the true value of that outstanding AR. So yes, the short answer is yes, it's very important. The long answer is that it's difficult. This whole process is difficult and takes a huge amount of time, and so it can be difficult to get everybody on the same page when they need to be.
Well, let me ask you one more question, and it's sort of piggyback onto that. Would you say that most of the cases of switching revenue cycle systems are sort of afterthoughts, meaning somebody's going on Epic, right? We've decided Epic more for the clinical side, so we get everybody on the same EHR, all our practices, all our physicians and all that. And oh, by the way, let's also do the revenue cycle, so we're on Epic for that too. So is it more of it just gets pulled along? And for the cases where it doesn't, what's the real impetus to take on this kind of workload when it's not being pulled along by a larger clinical side?
Well, I mean, so you mentioned Epic. I would say that I can't think of a single Epic customer we've helped through this process that didn't also use Epic billing. So I can't imagine a scenario where they wouldn't do that. So in the sense that it gets pulled along, yes, it does. But one of the reasons that they're moving to that new platform is often for a single unified, be-all and end-all. It never ends up being that, right? Even Epic has lots of ancillary systems that end up helping to support it. But it's taken for granted because of how well all of that works together. If you've got a single unified system, that when you move to something like Epic or Cerner, that you're going to be using their accounting modules to help track that revenue and do that burn down. So yes, it gets pulled along, but it's not necessarily an afterthought. It's actually one of the goals of moving to that system is making it the kind of be all and end all of all of your care and business delivery. So yeah, I'm not sure if I had answered your question.
And when it's not being pulled along, what is the impetus? I mean, what is the scenario that someone takes this on just because, oh, that system looks nice over there, I think that'll work a little better than what we've got?
Well, I mean, you can ask that same question about moving to any new system for any reason. Why do people move from their existing platforms to, one of the big winning vendors these days, whether that's Epic or Cerner or to some extent, Meditech, et cetera. And they do it because they believe it's going to derive additional value to the business, and that it's going to allow them to deliver care more efficiently and realize a greater return on their investment. And that becomes a harder thing to justify if you're using it piecemeal. Again, that's why I think virtually everybody that moves to one of these new platforms, it's assumed that at least on the patient accounting side, they're going to be using that go-forward platform's patient accounting system.
All right. Well, we could go all day, right? Because I like talking to you, Bob, and it is a very fascinating topic. But that's about it. I think we're going to have to end it here. So I want to thank you. When you close out your WebEx window, you'll be taken to a post-event survey. If you could take a moment and answer that, we'd appreciate it. For those of you with continuing education interest in today's event, if you have the Chime CHCIO certification, attending our webinars gets you 1 CEU. If you need a certificate of attendance for another program, you can use the final slide in this deck. You'll receive an email when our archive recording has been posted to our YouTube channel. And if you'd like us to produce a webinar on the topic of your choice, you can reach out to Nancy Wilcox from our team and go to our website to view our upcoming schedule of events. So with that, I want to thank our speaker, the brilliant Robert Downey. I want to thank our sponsor, Galen Healthcare Solutions, and I want to thank you, our attendees, for joining our events. So with that, everybody have a wonderful day. Thank you.
Thank you.